Hello, I am Dr. Nanette Silverberg. I am Chief of Pediatric Dermatology and a clinical professor of dermatology and pediatrics at the ICANN School of Medicine at Mount Sinai. I'll be talking at the Society for Pediatric Dermatitis this July on widespread vitiligo in a session that deals with how to deal with like harder cases or widespread cases amongst inflammatory skin disease. So I'm excited to be speaking about that. Um, it was a topic that I developed with the meeting creators because they had a vision of what would be included. It really reviews a lot of our recent research in my department and myself and the students and fellows at Mount Sinai have worked on a variety of projects, both as our, on our own, and then as well with our colleagues from Pedra and Idiom, who have been working with me for a number of years to develop robust pediatric vitiligo guidelines. Is really based on shared decision making and analysis of the patient. From when we look at our patients, we have to decide how much surface area they have. How rapidly they're losing color, and some of the indicators for severe or rapidly spreading vitiligo or Kepner phenomenon, and presence of confetti like lesions or trichrome lesions. So those are things we look for. Of course, it's important also as well to look at key sites. So the face is, of course, a very important to patients. It's been demonstrated that patients see the face 8 times more consequential as other parts of the body. So we really do concentrate first on clearing the face. And then we use our own guidelines. So I have worked on guidelines that were published in 2024 in JAMA Dermatology that address the use of topical medications through a consensus guideline approach. And that will include, it also includes a definition of vitiligo as a chronic relapsing inflammatory condition, and as well of vitiligo to be um, uh, uh, how we diagnose, with LAMP. But the main is that we have three options of therapeutics topically that have robust data: the topical calcineurin inhibitors, the topical steroids, and of course the FDA approved topical ruxolitinib, 1.5%. And of course, that is an incredible advancement for us to have an FDA approved product. And how so we do talk about first incorporating this into our treatment, and how do we deal with usage. That's the first, is if we have 10% or less body surface area, we can essentially use these topicals rather effectively. But we potentiate a lot of the therapies using systemics briefly to help us uh, try to get control. So that would be the currently available systemics. We will have further down the line off-label usage currently, but eventually we will have FDA approval of oral JAK inhibitors as well. So right now we do. There's a lot of data on pulsed steroids usage. There's some data on other agents like minocycline for short-term usage to gain control of the vitiligo. And there's emerging data on longer-term usage of JAK inhibitors. The older data has always supported and continues to support usage of narrowband UVB. And we have the opportunity now with some to have patients get better coverage for their home units of narrowband UVB. So that is also an opportunity to do at home or in the office. And we find from the literature that it depends what you've got. So we're going to talk a bit in this lecture about segmental vitiligo, which spreads rapidly. So that's like it's not necessarily widespread, but it spreads rapidly through the region involved, and so it becomes a very crisis to repigment. And we look at some of our data from our registry, which was developed with Dr. Paller's group at Northwestern with Dr. Paller, Amy Paller. And we were able to generate a lot of data about both non-segmental, so widespread or vitiligo would fall often under that, and then segmental vitiligo, which will rapidly move across a region. And so we look at in this talk, we're going to really focus upon that. So, the main thing is that there is some difference in speed of onset of repigmentation between the products, and sometimes when we focus on using topicals, the addition of ultraviolet light really helps us get that early control of disease so that it doesn't generalize as rapidly, so we can give people stability over a few months time period and then long-term efficacy. To repigment, we also have the ability to add in, again, these systemic steroids briefly, and then long-term, if we have people who are quite unstable, the JAK inhibitors will be available to us, I think, rather shortly, at least for adolescents. So sometime in the next few years, it seems like we may have that. But for now, we certainly do have more topicals, more data on them, and it's exciting to see that.